Bismillahirrahmanirrahim. Assalamu alaikum students. I welcome you all to another lecture of neurological physical therapy. And today our topic of discussion is interventions to improve motor function. I'm your course instructor, Dr. Ghulam, Fatima, assistant professor, Department of Health Sciences, University of South Asia. Okay, as you are very well aware that in our previous lectures we were discussing that what are the methods through which the brain undergoes recovery. Now we'll discuss that using those principles of recovery, how can we outline a framework of rehabilitation, or in other words, outwork of framework of practice. So we have to outline our framework of practice, and these are the topics of discussion for today. We'll discuss how can we outline framework of practice, what are the interventions to improve motor functions, what are the motor function strategies, motor learning strategies that need to be adapted, what is strategy development, what are different types of feedback, and what are different classifications of practice. These are the topics of discussion for today's lecture. And by discussion of these topics, hopefully by the end of this lecture, you people will be able to understand what are the basic elements of framework of practice, how different types of interventions are available for improvement in motor function, and what are the those types, and how you will select between them, and you will be able to understand how you can select and develop proper motor strategy according to the patient potential and requirements. So these are the learning outcomes of today's lecture, and you should be able to understand by the end of this lecture, you should be able to demonstrate by the end of this lecture that what are the basic classification of interventions, and then we'll be discussing those classification and types of intervention in details in the upcoming lectures. And you should be able to tell what are the basic types and basic elements of practice, and what are how you can control the environment and how you can control your practice and feedback to develop an appropriate proper motor strategy according to the patient's level and stage of motor recovery. So these are the learning outcomes for today's lecture. Now coming towards the very start of this lecture, what are the type of this lecture is that the first thing is that the therapist's role is to determine the patient's strength and limitation and to develop a collaborative plan of care that indicates goal and outcomes that match the patient's unique. The first thing you need to understand here is that every neurological patient is different from the other one. Like you can, in other musculoskeletal disorders, like if you see a patient of frozen shoulder, then majority of the frozen shoulder patient, they will be showing the same activity limitation, same presentation, same clinical sign and symptoms. But when it comes to the neurological patients, the patients differ from each other a lot. Every patient presenting to you, like say, take an example of stroke patient. Every stroke patient presenting to you can be on a different stage of recovery. They will have different strengths and different limitations. Their function limitations will be different. Their muscular strength will be different. Their comorbidities will be different. And moreover, their other functional requirements will be different according to the age they are lying in. So in neurological physical therapy, it is very important to always design a separate and custom-made treatment plan and rehabilitation plan according to the patient's need. And for this, the preferable thing is to always go for a collaborative plan of care, because you cannot do anything, you cannot achieve any goal unless and until the patient is cooperating with you. If the patient is cooperative, he is giving his full 100%, he is trying to achieve a movement, he is trying to put his effort in your collaboration, then is the only case when you will achieve something and there will be function induced recovery, because that type of recovery is only based on repetition and activity, repetition and practice. So if the patient is not ready for repetition and activity limitation, and he is not motivated enough, then it is not possible for you to gain any goal. So the result is that it is very crucial for you to go for a collaborative plan of care, so that patient feels that he is in command of his activity and he is a part of this plan, and he is responsible for making this rehabilitation plan successful. And not only the therapist is a facilitator, but he himself needs to perform actively to make the plan of care successful. So that's why it is very important to collaborate with the patient and come up with a collaborative plan of care. Now, on the framework of practice, it is always based on three basic elements, as we have already discussed, that every movement which is performed, it is like dependent on three elements. The first thing is the task, the activity which is being performed. The activity, it can be like some type of activity that only requires stability, like maintaining your posture, a stable posture that only requires stability. But obviously, the co-contraction of muscles is required for acquiring stability. Then there can be activities that are totally dependent on the mobility. And then in the latest stage of rehabilitation, we move towards the skill which is gained through practice and experience. We have already studied about the skill. So actually the task itself, what is the nature of the task, how easy it is, how difficult it is. So first thing is the movement itself, what kind of activity you are designing or you are prescribing for the patient. That is the very first element. Then the second and very crucial and very important element is the individual himself. Every neurological patient, he will have different cognition, as we have already discussed that many neurological events, they are like associated with some type of cognition impairments too. So the stage of cognition, level of cognition, how easily the patient can understand the commands and situation, and how difficult it is for the patient to understand the command on the situation, that comes under cognition. Then there will be different kind of sensory loss, and the patient can have different type of sensation and perception. Stage of motor recovery or stage of motor learning can be different for each patient. Like a patient may present with more motor loss of flexor components, the other may have more difficulty in controlling the trunk muscles, the third one may have more difficulty in controlling the knee muscles. So the motor function is different, activity limitations are different. The patient can have other comorbidities, the patient can have other neurological or severe sinus symptoms, or many other complications, health issues can be associated with the patient. So, and overall health status of the patient, that is another thing. So an individual is a combination of all those things: his physiological capacity, his mental capacity, his physical capacity, his cognition, his level of motivation, his activity limitation, his goals for the life and motivation for future like activity. All these are affecting the movement outcome. So the individual you are working with, it will uh, change and it will affect your whole rehabilitation program immensely. Then the third and the very important component is environment. What are the physical features of the environment? They can be like divided into two features. One is called regulatory and the others are called non-regulatory. We'll discuss both of these in detail. Now, environmental constraints always play a role in performance of your movement. There are certain elements that control your environmental component of a movement. Certain things, they are called regulatory features, and there are certain things that are labeled as non-regulatory feature. Now, regulatory features are the things that are essential part or essential component of that movement, like chair height. Taking an example of the chair height, like if the chair height is more, the chair is more heighted, that in the start of the learning stages, we will select a chair with more height because it is easy to perform the activity of sit to stand, standing up from a chair, that is quite easy if you started with a chair which has a high height. On the other hand, a chair which is deep or which is low in height, it is difficult for the patient. He will have to put more strain on the muscles, more muscle work is required, especially your hip extensors need to work at a greater range of motion. So more effort is required to sit up from a chair which is deep or which is low in the height. So this is the thing, that how a difficulty in the task can be achieved just by changing the situation. And this kind of condition is called regulatory conditions, that the environment in which it is performed, if it is directly and it is directly related and it is essential element of your movement, then it is called regulatory. On the other hand, there are some features which are not essential, but they do affect the performance, like if the environment is very distractive and the patient is unable to concentrate, sorry, or if the floor is slippery, or if there is less light in the room and the patient has visual issue. So all these are actually not a essential part of that activity, but these are the environmental conditions that are affecting the performance. So these are called non-regulatory features of that environment. So these are actually environmental constraints that do affect your movement, and they can be categorized into regulatory and non-regulatory conditions. So whenever you are designing an activity, you have to consider both of these, and the role of both of these is very crucial. Now coming towards the interventions that are a part and that are required to improve your motor functions, we can divide these intervention into three types of interventions mainly, and their order of preference is always from the top to the bottom. That your first preference, and you will always select on a priority basis restorative intervention. If you remember, we have already studied about recovery of function, that there are spontaneous recovery and there is a recovery that totally depends on function, that is function induced recovery. So your restorative intervention, they are basically based on the function induced recovery. And if you remember, we have studied about constrained induced movement therapy and body weight support therapy for the lower limb. So both of these types of intervention, these are dependent on recovery of function, and these are called restorative intervention, and we'll always prefer these type of interventions. I have already discussed many times that they have many benefits over other interventions, like not only by performing a function, all the muscle groups that are part of our synergy, all those muscle groups are activated. Your agonist, antagonist, your stabilizer, fixators, all those muscle groups are activated. You are working on the posture stabilization. Patient has to maintain the posture, so the stabilizers are working. Stability action is there, and the functional pattern is restored. And the thing is that is a practice of activities that need to be performed in the daily activity. So there are many fold benefits of restorative intervention. That's why they are ranked on the top. But the only drawback is that these type of interventions can be adapted when the patient has sufficient strength. If the patient doesn't have sufficient strength and flexibility to perform a certain function, then we cannot designate these interventions to those patients. So these are the interventions that whenever possible, they are the topmost priority. But this is not always the situation. So we do have other interventions too to help us. So other interventions are impairment specific and augmented intervention. Impairment specific interventions means the type of interventions, those that are specific to the needs of patient and the specific to the impairment. Like the patient can have a shortness of muscle, patient can have strength issue, patient can have endurance issue. So all those interventions that are targeted towards some specific muscle groups or some specific joints or some specific limbs and towards some specific impairment, that are like our impairment specific intervention. And along with that, we have augmented intervention. Augmented interventions are basically hands-on assistant type of interventions that require assistance from the side of the therapist. These are mostly guided or assistive movements, and neuromuscular development techniques are a part of it. And the one example can I quote here is just like as you see PNF techniques. So all those techniques are actually augmented interventions that help us to overcome the impairments and speed up the recovery process. So these are tools that are available for us in the form of interventions that we can make a part of the patient's plan, and it is our priority, our clinical decision making, that we select the intervention, or we may combine these intervention. So we'll select intervention, or we may combine these intervention according to the patient requirements. Okay, there are certain patients, as I have already discussed many times, that there are many situations where recovery, functional recovery is not possible. Either your cell bodies are damaged or the recovery of that part of pain is not possible. So in that case, we will go for compensatory intervention. So if the patient has some severe kind of impairment, like contractures are there, or the patient prognosis is not good, or the patient like there are very little chances of recovery of function for that part, or there are multiple comorbidities, there are other issues too, that you don't think so that patient can perform a specific function, then we have the facility to go for compensatory interventions. As the name shows, that either we will teach him another pattern of movement, or we can use make of substitution and performing the activity in a totally different way by using another name on another part of body, or sometimes we may use some other assistive devices. So these are the compensatory interventions. So these are the tools that are in our hand whenever we are planning some kind of rehabilitation plan. We can choose one of these tools or many of these tools or combination of these tools, and then we will make a treatment and rehabilitation plan for our neurological patients. Now coming towards the interventions, these are basically the interventions, and we will discuss these interventions in detail in upcoming lectures. So on the other words, you can say this, these are an outline of your rehabilitation plan and rehabilitation framework, and we'll discuss this in the upcoming lectures, and an outline of your next upcoming lectures is also dependent on these. First, interventions where we have just discussed that these are our always our topmost priority. These are restorative intervention. These are actually based on the functional training of the patient. So we will always go for the task specific training. Just as I have already mentioned that constraint induced movement therapy is an example of task specific training, and body weight supposed walking there, that is also an example of task specific training. Then functional mobility skills can be a part of it, activities of daily living. Then it also depends on your environmental context. Behavioral shaping is required, and the safety awareness training is required. We will discuss all these points one by one in our upcoming lectures. Then to make these functional trainings and all the rehabilitation process successful, we have some other things we have to consider, and we have to plan our motor learning strategies. So strategy development is a part of it. Feedback, what kind of feedback should be given, what kind of practice should be given, what is transference or transfer activity, the concept of transfer activity, then active decision making. These are basically the topics and the points we'll be discussing in the upcoming slides, so you will develop a better idea what is meant by these. These are, you can say, a core or the background of your activity. Whenever you are planning a rehabilitation program, you will be planning that what kind of practice is required, what kind of feedback you will be given, what kind of strategies required, and then you will be making the patient an active part of your decision making process. Then coming towards the other intervention, I told you that we have impairment interventions, we have augmented interventions. Coming towards the impairment interventions, they are according to the specific impairment. We'll be discussing in a greater detail about this intervention in one of our lectures. Impairment interventions involve strength, power, endurance, flexibility, posture control and balance, coordination and agility, gait and locomotion training, aerobic capacity, endurance, and relaxation. All of these are labeled under the impairment intervention. Then we have augmented interventions. Augmented interventions, there we have neurodevelopmental treatment, NDT, called famously neuromuscular facilitation, which is also called ENF, sense stimulation, biofeedback, neuromuscular electrical stimulation. All these are termed under augmented interventions. So we'll be discussing these two again in a separate lecture. Then we have compensatory intervention, as I have already mentioned, that these are substitution training when we have some severe physiological impairment and there is a patient is not able to perform or there are very less chances of recovery, then we can go for the assistive and supportive devices. So these are all the components that are required, just like a puzzle. You will uh, match the components that are required according to the patient. You may require restorative interventions, you may require impairment intervention, you may require augmented intervention, and you may sometimes require compensatory intervention. So this is a combination of all of these interventions that will lead to a successful rehabilitation program. So next, in today's lecture, we'll discuss the motor learning strategies that are actually a basic core of practice, any type of practice and any type of rehabilitation framework. So these are at the core of that. For every exercise plan, for every rehabilitation plan, you should be well aware of these strategies being a therapist. So what is the concept of strategy development? What is meant by strategy development? Well, it means the strategy you will adapt for the rehabilitation program of the patient, and it always varies according to the stage of motor learning. As you have already discussed that there are 3 stages of motor learning, starting from the very basic stage to the advanced autonomous stage. We have 3 stages, so you have to decide according to the stage of motor learning of the patient that which type of strategy will be most appropriate for the patient. Now, in the start of these rehabilitation program, most of the time the patient doesn't have enough strength, and we rely on the guided movements, and the physical therapist is playing the main role. He is assisting the patient manually. He is like trying to help the patient to perform a task. So in the early stages, this is required because the patient doesn't have enough strength, and it is very important for the patient to build up some mind maps. So in the start of the rehabilitation program, these type of guided movements and these types of passive activities, you can take an example of that, passive range of motion exercise, or you can say assisted activities. These are requirement at the start of the rehabilitation program. But the thing is that as the patient condition progress, you should always reduce your guidance, reduce your feedback, and reduce your role in the patient activity. Patient should perform active movements as much as possible and as soon as possible. Let me tell you, if a patient is just performing passive movement, there will be no strength gain, and the patient will not be able to move actively and gain any strength only by the virtue of passive movements. Passive movements do help us to maintain range of motion and to maintain the flexibility of the muscle, but that do not help us for strength building that is required for the patient. We have to motivate the patient to perform actively and to play his own part in the movement. Only then the patient will progress, and only then the patient will can be able to perform an activity independently. So the key is always reduce your guided movements, reduce your assistance whenever possible, and make the patient work. Although this is more difficult to make the patient work and to again and again give him cues and motivate him to perform the activity, but this is the only way then there will be success. So as I have already mentioned that we do have many different types of feedback, and firstly the two broad categories of feedback, one is in your control and one is occurring naturally as a result of movement. So the one which is occurring naturally as a result of movement, which it is called intrinsic or inherent feedback. Whenever an activity is performed, joint movement is there, so it means proprioceptive receptors are fired. Then if the patient is looking at the limb, and let me tell you, this is a very important part, that always ask your patient to look at the limb at which activity is performed, at which movement is performed, because it will give visual feedback to the mind. Then whenever there is head movement, there will be vestibular feedback. When if you are touching the patient, it gives cutaneous signal. So we have, and the muscles are moving, their spindles and their receptors are being fired. So these are the inherent feedback or intrinsic feedback that is inbuilt in the movement. Whenever the movement is performed, this kind of feedback is automatically generated, and this kind of feedback is like stored in your mind. There is another type of feedback which is called extrinsic or augmented feedback. This is in the hands of the therapist. These are the sensory cues which are not normal part of the activity, but will provide them, like verbal cues. If the therapist is encouraging the patient and giving reinforcement words like do it, very good, very well. All these are verbal cues. Manual cues, if you are tapping, if you are touching, all these are manual cues. And for a very you can say very calculated amount of feedback can be given through biofeedback devices. The main principle of biofeedback devices is based on giving the patient a feedback of their performance. Just like after going through any test, you people like to have some feedback of your performance. Same is the case with the patients. They like to have some feedback and they feel encouraged when they know that they have performed certain activity successfully. So feedback is very important, and extrinsic feedback is totally in your hands. So this is the type of feedback which can be controlled by the therapist. Your augmented feedback, this is the type of feedback that can be controlled by the therapist. So we have different types of augmented feedback that we will select according to the situation of the patient. The first one is called concurrent feedback. This is the feedback which is given along the movement. When the patient is performing the movement, along with that performance, we will give this kind of feedback. So this is called concurrent feedback. Then there is another type of feedback that is called terminal feedback. This type of feedback is given when patient has completed the movement. Like if I ask the patient to lift the arm, the concurrent feedback will be given during the process the patient is lifting the arm. I can say like straighten your elbow, straighten your hand, or any of such command that will be called concurrent feedback. But if I keep quiet during the performance, and after the completion of the movement I say okay, well, but next time please straighten up your elbow, this is called terminal feedback. So terminal feedback is again of two types. We can give the feedback immediately after the movement completion. This is called immediate feedback, and sometimes we can give a slight delay in feedback, and that delay is required so that patient can guess his own mistake. So if the patient gets his own mistakes and like he can verbally communicate with you, or if he doesn't communicate it, even he will like incorporate that in his next performance. But if you give a certain delay, but this delay is it should be limited to very limited life, like 3 to 5 seconds. If you give more delay, then the patient may distract from that particular movement, and he may start thinking something else. So delayed feedback are given sometimes, and the purpose is to give some time that allow for self-assessment for the patient. So this is another type of feedback. Then we have summary feedback. This is a type of feedback that we let the patient try. Like he will try 2 to 3 times, and after that we'll give some feedback. In that, patient will have a chance to correct the next performance. Maybe he's doing the first performance, but he understand that this was mistake in that performance. He will try to correct in the next one. So in summary feedback, we will give feedback after after a number of trials, like a set number of trials, like after every second trial, after every third trial. That is your choice, that what you decide that you can give feedback after every third trial. So this is your choice. Then there is another type of feedback that is called faded feedback. Feedback is just like starting with the grade and then diminishing the feedback. This is faded feedback. Like in the start, you can give frequent feedback. You can give feedback after every trial, but then you start to reduce the feedback. Like first you will give after every trial, then you start giving after every third trial, then after every fifth trial. So this kind of feedback that is reduced gradually in one session we're discussing, this is called faded feedback. Then there is another type of feedback that is called bandwidth KR feedback. KR is actually knowledge of result. So knowledge of result feedback, we have two types of knowledge. Either we can have knowledge of result or we can have knowledge of performance. Knowledge of performance is based on how accurately you are performing certain activity, and knowledge of result is based on the achievement of the goal. Like if you ask the patient to touch the wall, now in one case you are only focusing on if the patient is able to touch the wall. That is called knowledge of result. On the other hand, you are checking each and every step of the patient, that if he is walking in an appropriate way, if he is lifting his leg correctly. That is called knowledge of performance feedback. So both of these are a part of your feedbacks. But talking about the bandwidth KR feedback, this is the feedback we only give when your performance that deviates from the correct performance. Like when the patient is on this type of feedback is only given when the patient is at some higher level of recovery and higher level of motor learning, and the patient is able to perform the activity by himself, and you have already given a lot of feedback. Then at this point, at the next level or advanced level of rehabilitation, you only prefer to give feedback that if the patient is making a mistake again and again, or he is like means that the mistake is becoming a part of that performance, and then you will give that feedback. Or sometimes that the patient is performing correctly, but very seldomly he makes some mistakes, then a feedback is given. That kind of feedback is called bandwidth KR feedback. Then we have blocked feedback. Blocked feedback is a type of feedback, as the name shows, that you will only focus on one segment. And this is on the patient is giving repetitive trial, like the patient is performing the sit to stand, but you are only focusing on knee control. Or on the other hand, you are only focusing on hip extension. So if you are in repetitive trials, or you are only focusing on the same segment again and again, this is called your blocked feedback. So you will only give feedback about your specific segment. This is called blocked feedback. The benefit is that the function and the performance of that part will be perfected, but the drawback is that the whole task and the performance of the other parts of the body, they will not be improved. But in certain patients where you find that the performance is that only there is problem in one or two part or that are more crucial to like rehabilitate, then you can give blocked feedback. So where you can give only feedback regarding one part, one segment, one part of your body. Then we have variable random feedback. It is when multiple sources of feedback given. Like first time you are giving about hip, then in the next you may give feedback about your knee, and then you may give feedback about ankle control, your trunk control. Like you are giving multiple sources of feedback, and you are giving feedback on different body segments. So this is called variable feedback. So this is your choice what kind of feedback you will choose according to the patient condition. Then comes towards the practice. We know that practice makes a man perfect, and in a logical patient's practice and more practice of an activity is required for the patient to relearn that pattern, because we are trying to achieve motor recovery that is based on neuroplasticity, and that neuroplasticity is based on long-term potentiation, and that is based on your practice and the recent patterns of activity, and your whatever you the activity or the motor pattern you are performing, that will lead to recovery of function. So functional recovery will be there as a result of practice. So that's where practice is a very crucial component. So we have to understand what are the general principles of practice. The first thing is that more practice means more learning, more motor learning. The patients who are very enthusiastic, the patients who are very motivated, they make it very quickly. Their motor recovery like takes place in less time as they try to like practice a lot. So that's why their improvement and their progress is quick as compared to the patient those are not motivated enough. Then another point to remember is that the large and rapid movements, like movements of your shoulder or movements of your hip, these large and rapid movements, they are like initially observed. Their restoration is quick. But the small, very fine movements of the hand, like writing or very fine movements of the hand, they are the last one to recover. They take more time, and many different muscle groups, small muscles and different muscle groups are required for any fine movements, but very large movements and rapid movements that require less control, they are initially they will be recovered in initial stages. Then other thing we need to remember is that if the patient has developed any faulty habits, any trick movements, and any faulty posture, the first thing is to unlearn that. Because first the patient will unlearn the faulty posture. After that, we will make him learn the correct movement. So the first thing is, if the patient is developing some faulty habits, like if he is trying to make some hump of his back during performance of the movement, or like he is trying to use trunk muscles to lift the arm, you need to first unlearn and discourage these incorrect patterns. Then you will make him understand the correct patterns. Then always consider patient's physical and psychological, cognitive, and overall health status before deciding a task and the type of practice for that patient. So as we have discussed enough that there are many different types of practice. One type of practice is called massed practice. Mass practice is the one in which the rest time is less and practice time is more. This is called massed practice. Obviously, one is preferred in the later stages. But there is another type of practice which is many times required for the neurological patients. These are called distributed practice, where your rest time is either more or sometimes or at least equal to your practice time. So when the patients are weak, when the patient has mental or physical fatigue issues, then you will go for the distributed practice. Obviously, the mass practice that will be more demanding for the patient, and distributed practice is less demanding for the patient, as will give frequent rests for the patient. And there is more learning in the distributed practice, but the thing is that the time, total training time, will increase, obviously, because you are giving frequent rest periods. Then according to the practice sequence, we have certain types of practice. One is called blocked practice. In it is simply that you will perform one activity repeatedly without any other. Like you can perform a set of sit to stand, again 10 sets of sit to stand, then a break, then again 10 sets of sit to stand. So if you are only performing one task repetitively, this is called blocked practice. And opposite to this, there is a practice that is called random practice, where variety of tasks are ordered in randomly across trials. Like you are performing different type of activity. Like once you are doing some sets of sit to stand, and then you are doing leg raises, then you are doing bridging. So if their variety of tasks are ordered randomly, so these are called random practice. So it has shown that although as a result of block practice, that specific task that is like learned quickly, but in terms of long-term retention and long-term learning and long-term part of a memory, then random practice is more effective. Now there is also certain types of practice based on the order of practice. One is called blocked practice. In blocked practice, you will perform like three trials of one task, then three trials of another task, then three trials of another task, or you can say five trials of one task, five trials of another task, five trials of another task. Like you can say five trials of sit to stand, five trials of after that five trials of knee straightening, after that five trials of bridging. So this is called blocked order. Then there's an order which is called serial order, when where everything is like jotted down in a series, and an order is used for repetition, like sit to stand, then a leg raise, and then bridging. Again sit to stand, leg raise, bridging, sit to stand, leg raise, bridging. So predictable and repeating order is there. So this is called serial order. Opposite to serial order, there can be random order. That the patient is like practicing in a non-predictable and non-repeating order, like sit to stand, bridging, and after that the patient will perform leg raise, then a bridging, sit to stand, then leg raise. So any unpredictable order can be adapted for that. That is called random order. Now, as I have already told, that the block practice, it produce early acquisition of skill. The patient can learn quickly, but the other, like especially the random, your serial, and these kind of have they are retained for a longer period of time, and the patient can generalize these skills to other activities, and use these activities as a part of other activities too. So that these are like, now you will decide what is the requirement of the patient. According to that, you can choose the practice type. Then we do have practice strategies. One is called mental practice. This is truly an amazing thing, mental practice. This is that the patient, especially for the patient who are unable to perform physically, like whose muscles are in a flaccid stage or who are paralyzed, it is not possible for them to actually practice by physical means. Then we go for the mental practice. The patient will imagine himself and visualize himself doing the same activity, and the studies say that there is activation of the same areas of the brain that would have been activated if the patient has done the actual movement. So this is a very amazing thing. And just like that, before usually going for any like competition. You always rehearse in your mind that how you will go through each and every event. So for every patient who fatigue very easily and who cannot perform the physical practice, for them you can go for the mental practice. And if the patient has the chance to do both of these, combining the mental and physical practice, that will give you very much better outcomes. So mental practice is such an amazing thing that only rehearsing in your mind, only imagining and visualizing your mind, even that have a positive effect in your mind. So that's why I think that positive thinking is always encouraged, and it is said that what you think becomes what you do. So that is an example of here. Then there is part versus whole practice. This is the where that the a simple task that is divided into component parts, and rather than practicing the full task, the patient will first practice the component parts of that task. Like if I say the patient wants to eat, this is a full task, but it can be divided into different components. Like first the patient can practice just holding the spoon. Patient can practice elbow flexion. So the task can be divided into simple component parts. This is called part versus whole practice. Then we have transfer training. Transfer training is the thing when the patient, like sometimes if the patient is not able to perform activity with the affected limb, what can we do? Meanwhile, we can use the contralateral extremity, and it is seen that by using the contralateral extremity, there is some transfer of training to the affected limb. As you know, even when this is not moving, if we are doing some resisted training of normal part, then this other limb, the other part of the body, that has to work as a fixator, and it has to stabilize the body and work as a fixator, and it has to stabilize the whole body. So its muscle has to be called in, its muscles has to be recruited. So actually the uh, result of as a result of practice or experience of some other task, if there is some gain in performance, this is called transfer or training, and sometimes we make use of it. Like if we cannot perform an activity on a particular part, then we can use some other part, that and flow of effort will be there. Then we have practice of led up activities. This is simply that another version of that movement is performed by the patient, and the simpler version is performed by the patient, and then complex tasks will be performed ultimately. Like a very good example of that is that if the patient has to do sit and stand, first we will make him do bridging, because the hip extension that is required in the bridging, that is also a part of sit to stand. We need to do your hip extension. Then you can make him do foot slides, and that are required during again sit to stand. So simpler versions of that activity can be performed, and that is called practice of led up activities. Then again, this is very important to promote active patient decision making and autonomy. And the patient, not only it will boost the confidence of the patient, not only it will boost the motivation of the patient, but it will help him in a learning process, in a problem solving situation, because the patient has to make decision for himself when he is out of the clinic. He has to decide for himself. He has to be confident enough to take some risk and do some activity. So you have to tell him to make him decision for himself when he is has to tackle with the real life, where there are safety issues too, but he need to perform his daily activities, he need to perform independently. So when you make the patient a part of decision making, give him some and you are giving him some kind of autonomy, it will boost his confidence, it will polish his problem solving skills, and it will help him in learn a lot. So that's all from today's lecture. So what are the take-home message? That we have a variety of tools and interventions available and we have to select out of them according to the patient's potential and the patient's stage of recovery. And the other thing to remember is that every patient needs a different motor strategy that should be progressively challenging according to the patient's situation and the environment and the task that should always be challenging for the patient. Thank you so much for being with me in today's lecture, and I hope it will help you in your clinical settings, and you will part it a permanent part of your. You will make it a permanent part of your memory and remember all these points whenever you are working with neurological patients.